So great to see you all here. I'm really honoured, in fact, to present this data on behalf of the people that worked so hard to get this here today. We are really here to think about ways in which together we can improve the outcome for patients with prostate cancer in Victoria. And that's because men with prostate cancer face difficult decisions when they are diagnosed with prostate cancer. They have to go through the treatment and understand the treatment, and after the treatment they have sometimes difficulties with the survivorship afterwards. They have often difficulties with the impact on their quality of life, and otherwise, if they progress, they might need to go on to other forms of treatment, and that's sometimes quite difficult for them. And finally, of course, we should remember that it's sometimes difficult for them to access clinical trials, and we might want to think about how we could improve that. I'm going to talk about the data. This is what we see from the data sets that we have. I'll talk about the incidence of mortality, the characteristics of the patients who we diagnose with prostate cancer, and the care patterns and the variation across the state and the difference in outcomes across the state. So hopefully this will give us some opportunities for discussion and insight into things that we might be able to improve in our local regions and our local health services. The framework for this is the optimum care pathways, and Professor Thomas told us about those. These are available and they've recently been updated to reflect the recent NHMRC guidelines on prostate cancer, on PSA testing. They are broken down, as you can see, into 7 sections. We'll probably concentrate on these sections in here, on the presentation, the diagnosis, and on the treatment, because that's where the best data is, and that's perhaps a reflection for us that we have information on this initial part of treatment, but we don't have so much data on what happens after treatment, and that's something that we can talk about during this presentation and afterwards. The parts of the man's journey that we're going to talk about will be illustrated by data from these data sources. So we have a linked data source from the Victorian Cancer Registry to the Victorian Admitted Episodes data set, which is the VAED, and to the Victorian Radiotherapy Minimal data set. So these are linking patients with prostate cancer to what happens to them in the health service where they are treated. In addition, we have the Department of Health Cancer Performance Indicator Audit. So we have some information from some work that they have going on, particularly multidisciplinary meetings and the proportion of patients who are discussed and their care is discussed in multidisciplinary meetings. And then finally we have the work from the Prostate Cancer Outcomes Registry, which is a cancer quality registry which covers most of the state now, and is a registry which is intended to provide rapid and timely feedback about patient-reported outcomes and patient patterns of care and management outcomes to the clinicians who are looking after these patients, and we'll talk more about that as we go through. So more about the linked data set. This is an administrative data set, so it comes from the hospitals. It's data reported to the department. It's a very rich data set, and it's population-based because it covers the entire state, public and private hospitals, and it's linked to the entire cancer incidence reported to the Victorian Cancer Registry, which is the mandated repository of cancer diagnoses. This linkage allows powerful mapping of patients and their journey through the cancer care system if they have prostate cancer. The Prostate Cancer Outcomes Registry is based at Monash. It's very generously supported by Movember as part of a now growing initiative across Australia and internationally. It began in 2009 and rapidly grew to now cover 36 of the participating of 36 of the health services in Victoria. We have over 12,000 patients with details entered onto the registry now, and we cover 75% of the state with some gaps in the Hume region, in the peninsula down southern Melbourne, and in the Grampians region. The point of the PCOR is to provide regular reports back to clinicians who are looking after patients and to institutions about the quality of care, and to engage in a dialogue with those institutions about what's going well and what might be improved, and to follow up these patients in a longitudinal fashion to be able to show improvement and to encourage improvement. And I'll show you some data about how that's been able to be achieved. This is a quick table which shows the some of the characteristics of the data sets. You can see that the administrative data sets are very large. They have a lot of administrative data in them, 31,000 patients in the in total in the VCR that we'll be looking at. We're only looking at the date range where it's linked to the VAED. So of course the VCR goes back to data since 1982, and we'll briefly touch on that. The prostate cancer registry is an epidemiologically sound, more parsimonious data set, but the data items are particularly targeted at things that relate to the quality of care and the patterns of outcome. And the unique thing about this Movember-supported cancer registry is the way in which we go back to the patient and ask them how they are. So we're looking at patient-reported outcomes. We're looking at outcomes that are important to patients, and I'll mention how that works. In order to think about the variation across the state, one of the divisions that we use is the X boundaries. So Professor Thomas has already talked about how these geographically divide up the state. The VIX organisations, you all know, are agencies which are designed to encourage improvement in cancer health care in their regions, and they particularly take advantage of the regional health centres, regional cancer centres, which are supported by both the federal and the state government in each of these X. So you can see that each of the metro and the regional X are associated with a regional cancer centre, and they act as a focus for cancer care within those regions. So on with the data. First of all, the umbrella view, what happens in the big picture over the long period of time, and this is a remarkable graph, really. I think it shows a very surprising, at least to many people in the room at the time, decrease in the incidence of prostate cancer since peak prostate, which was 2009. The age standardised incidence of prostate cancer has decreased from 134 per 100,000 population to 84. So it's a decrease of 39% in just the 5 years. And this is age standardised, so it takes into account changing age structures of the population, and also the growth of the population. So this is a real phenomena, and it's very notable. Obviously, the other thing underneath there is the mortality rate over the long term. So this shows mortality rate in Victoria, again age standardised. So this is taking into account the growth in the population and the change in the age structure of the population, and the mortality rate increased from the first figures available in 1982 through to 1994, from about 16 per 100,000 people to just over 20 per 100,000. And since then, since 1994, it's been decreasing at the annual rate of 2.5% per year. So it's down to just around 11% per 100,000 people now. So there has been, we're pleased to say, steady progress in the population mortality of men with prostate cancer. And that's it's a sort of remarkable picture, and the question comes up, well, is there something different going on in Australia? Well, no. The interesting thing is this pattern seen around the developed world, and there are similar patterns of peaks and then declines in the incidence of prostate cancer seen in other countries. And the interesting thing here is that there's differences in the time period for these peaks. Now, this data is from a global organisation. It goes up to 2010, so it doesn't give the most recent data, but we're seeing the same patterns in many Western countries. Now, one of the questions that comes up is, well, what's causing this? And the obvious association is PSA testing. And it's very easy to see that the pattern for PSA blood tests shows a very similar profile to the pattern for the diagnosis of prostate cancer. And you can see that the use of PSA blood testing peaked a year before, 2008, before the peak incidence of prostate cancer, and has steadily fallen. And it raises a question about men who presumably have prostate cancer who now aren't being diagnosed because of this decreasing rate of the use of PSA blood testing. So now we get on to a bit of data about the variation of cancer incidence, because we've seen how it's changed over time, but how does it change over space, as it were? And this shows the differing incidence of prostate cancer on an age standardised basis by different regions in Victoria. And you can see that that Gippsland, for example, and Western and Central have lower rates of prostate cancer diagnosis, and the Northeastern and SMICS have higher rates on an age standardised basis. So there's quite a notable difference there in the rates of prostate cancer by region. And it's obviously a curious thing. Why is it so? This might be part of the explanation. So we can slice and dice this incidence of prostate cancer in a number of different ways, and this is looking at it by socio-economic class. So this CEFA is the socio-economic index for area, and this allocates men to a very small statistical local area. There's 55,000 of them in Australia. It's an area of between 200 and 800 people. So it's a very small area, and we can assign socioeconomic class to men on the basis of where they come from. And you can see here that essentially if you're in the highest quintile of socioeconomic class, you're more likely to be diagnosed with prostate cancer. And if you come from the lowest 20%, then you're less likely to be diagnosed with prostate cancer. And that's of relevance because if you look at the distribution of socio-economic class across the different regions, you can see that in Gippsland, for example, there are large numbers of patients in the lower socio-economic class, and relatively small numbers in the highest 20% of socio-economic class. And the pattern is completely reversed in the leafy suburbs of northeastern Melbourne. So this accounts for some of the difference in the incidence of prostate cancer. Moving on to mortality, I've got two figures on mortality. This one is population-based age-specific mortality from the Cancer Registry, and it shows that the age-specific prostate cancer mortality is higher in regional areas such as Gippsland and the Grampians, and it's lower typically in the metro areas. So we're seeing differences in mortality from prostate cancer depending on your address. Now we can think about trying to correct for factors such as age and disease stage, because we know from the Cancer Registry some of these details, and so we can work out with the help of statisticians the prostate cancer specific survival. So this is a different graph. This is now comparing the hazard ratios for prostate cancer death in the different regions. And so it's looking at mortality from prostate cancer in the more recent time, since 2008, and adjusting now for the socio-economic status, the age, and a summary stage. And so what we're seeing here is a very similar pattern. We're seeing that if you come from regional areas in Victoria, the mortality is higher, and if you come generally from metro areas, it's lower. The group that's changed there is the Hume. So when we've corrected for age and socioeconomic class and summary stage, the patients from the Hume are doing better. One question might be the cancer incidence in by socioeconomic class. Well, it doesn't make much difference. So while you're more likely to be diagnosed with prostate cancer if you are in the highest quintile, the chances of dying from prostate cancer are about the same. So now I'm going to start to talk about the presentation of men with prostate cancer and their initial investigations and referral. More than 85% of men who are under the age of 65 or 70 are not diagnosed because they present with symptoms. They are diagnosed by case finding they're asymptomatic. As men get older than 70, then a higher proportion of them will be diagnosed because they have symptoms, mostly obstructive symptoms. This varies depending on where you are in the state. So we see this is from the Prostate Cancer Outcomes Registry, we can see that you're more likely to be diagnosed with obstructive symptoms if you come from regional Victoria rather than metro Victoria. The Prostate Cancer Outcomes Registry also shows there's a variation over time and space for the method of diagnosis. So this is quite a notable slide too. This shows that in 2011, you can't see the little grey area there, represents 0.3 of 1% of all men who are diagnosed with prostate cancer were diagnosed with a transperineal biopsy. Jeremy Grummett's taking a picture. We'll give you the slide, Jeremy. It increased in the last year in which we have data to 25.5%. So there's been an enormous expansion in the number of men who are diagnosed with a transperineal biopsy. But this varies also across the regions. Now this might represent differences in the speed of uptake of transperineal biopsies by region. So it may be that all regions will get up to 25% over time. This is the entire period from 2009 to 2014, but you can see that some regions, such as Barwon, are less likely over that period of time to have a transperineal biopsy diagnosis, and metro areas in southern Melbourne and northeastern Melbourne more likely to have diagnosis from transperineal biopsy. This is from the Prostate Cancer Outcomes Registry. The other thing that, if we look at variation in diagnosis, is the PSA level at time of diagnosis. So this comes from PCOR. It shows that men in regional areas such as Gippsland, 20% of these men have PSAs of over 20 at time of diagnosis, whereas if you come from SMICS, for example, it's about 10%. So you're twice as likely to have a PSA over 20 if you come from some of these regional areas. And similarly, if you look at it from the other end, if you look at the proportion of men who are diagnosed with a PSA of less than 4, then in Gippsland, that's only about 10%. It's about double that if you come from, say, southern Melbourne, the SMICS region. So there's very big differences in the PSA levels of men in different regions, and that's also reflected in the grading. So this is not quite so easy to see. The differences aren't necessarily so large on this graph, but if you look at the Gleason score 8, 9 and 10, so these are high-grade tumours, the difference between the metro areas and the regional areas is 3 or 4 or 5%. And because these men are men who are particularly likely to progress quite quickly, they represent an important group of men who will drag down the survival figures for those regions. The Prostate Cancer Outcomes Registry, because it's got this granular epidemiologically sound data can assign men to the NCCN risk groups. So the NCCN risk groups are an aggregate risk adjustment to allocate men to groups who have similar outcomes for their prostate cancer with treatment. So the NCCN allocates men to low risk, intermediate risk, or high risk as a overall picture. And you can see that there's a very big difference in the different regions. So if you, for example, come from Barwon, almost 20, it's 10% of these guys, I've forgotten the figure, a large proportion of these guys present with metastatic disease. And if you look at the metro areas, it's about 5%. So there's a huge variation. If you presenting at diagnosis with metastatic disease, obviously the outcome is going to be worse in that area. If you look at the combination of the high-risk men and metastatic men, more than 40% of men in some regional areas, such as Gippsland, are in those high-risk or metastatic disease groups, and that might well account for different outcomes for men treated from those regions. One of the things that the VICS and the government are keen to do is to encourage the discussion of men's care in MDMs. In Victoria, there's been a huge uptake in the discussion of men in combined clinics with multiple specialties present, and this is particularly seen in breast cancer, where the almost over 90% of patients are discussed in MDMs. There are MDMs now in most regions of Victoria, and breaking news, I was told by Mr. Cato that they had the first one in Mildura in the last week or so. So they're popping up around the state. The government, through the Cancer Strategy and Development, do audits of the proportions of men who are discussed in MDMs, and it's quite variable across Victoria. So the first thing you can see is that men with prostate cancer are less likely to be discussed in MDMs than, for example, patients with breast cancer. It's very much less than the target range, which is about 80%. And you can also see that this varies dramatically across the state. It's more likely to have discussion in MDM in metro areas than regional areas, and also across the metro areas it does vary as well. Another thing which might influence the outcomes is access to treatment, and this is data from the Prostate Cancer Outcomes Registry. They looked at the time to treatment from diagnosis to treatment. This is the median and interquartile range showing, and you can see there that in the northeastern metropolitan area, the time to treatment is about half what it is for men with intermediate risk disease. So this is looking at the same risk group than it is, for example, in Grix or the Loddon Valley. So this also might weigh into the differences in outcome between the men treated in different regions. So this is now treatment. I'll show you some slides about the different treatment options for men treated with prostate cancer across the state. This is the rate of men having prostate cancer prostatectomy within a year after diagnosis. And so across the from left to right, that's the year, and from top to bottom, that's the different region. Now, one thing I should mention is that I'm going to show a whole lot of slides in these regions. These different X regions are in the same order. So if you have a favourite X, if you keep your eye on the level of the slide, you'll be able to follow your favourite X. So NEMICS is up the top here. The rate of prostatectomy is shown with a colour. So it ranges from about 18% to 50%. 50% is dark black, and the 18% is almost white. And so you can see there that there's a huge range of prostatectomy, depending on which region you come from. And you see that perhaps in the regional areas it's been slowly increasing over time. In some regional areas, though, there's obviously less prostatectomies performed, and we might not be surprised by that because I've shown you data already about the way in which the risk groups of the prostate cancer varies across the state. One of the interesting things about prostatectomy then is where are these being done? And in fact, they're done in 42 hospitals across the state. This is a chart showing the volumes in a single year. So this is annual volumes of prostatectomy across the state, breaking it up by private and public. And we've drawn a line which is at 10. So you can see there's almost a dozen hospitals where there's less than 10 prostatectomies done per year across the state. Now, one of the questions here might be that what is the experience of the surgeon? Because it might be that there's a surgeon who does 1,000 prostatectomies a year who's done one in a hospital which is only doing 10. So that's one of the debates that we have about the volume factor in prostate cancer. This is a slide which shows the volume of prostatectomies depending on your socioeconomic class, and it's also broken up by private and public. So it shows that if you're in the lowest quintile, you're still more likely to have your prostate cancer treated surgically in a private hospital than a public hospital. But as the socioeconomic class of the patients increases, they become increasingly likely to have prostatectomy in a private hospital. In contrast, in public hospitals, as the socioeconomic class goes up, you're less likely to have prostatectomy in a public hospital. This is a slide which shows a relationship between the region of residence and where patients have their prostatectomy. So if you bear with me, I'll take you through it. Across the top is the region of residence, and down the left-hand side is the region of the prostatectomy. And so the diagonal, which is the intersection of the region of residence and the prostatectomy, is the common box. It's patients who have prostatectomies in the region if they come from the region. So you'd expect that that would be high if you have your operation in the region that you come from. And you can see in the metro areas, it tends to be high. So if you come from, now, I'm not sure if, hopefully you can see that, but I'll explain it. If you come from a metro region, then between 60 and 75% of the operations are done in the same metro region that you come from. And most of the movement of patients for their prostatectomy is into adjacent metro areas. So the metro patients are mostly having their prostatectomy within Metro Melbourne and mostly within the metro area they come from. It's also true in some of the regional areas. So in the Grampians, for example, a high proportion of patients who come from the Grampians have their surgery in the Grampians region, and there's not much movement outside the Grampians region. In contrast to that, in the Gippsland region, the vast majority of patients will have their prostatectomy in Metro Melbourne. So only a very small proportion, about 10%, will have their prostatectomy in Gippsland. So you can see that when we think about the outcomes of patients, and if we think about the influence of surgery on that, the surgery for patients who come from Gippsland isn't done in Gippsland mostly. Now moving on to other options for men who have prostate cancer, there's a huge variation in the distribution of surgery or radiation or androgen deprivation. This comes from the LINC dataset. The LINC dataset doesn't have information on androgen deprivation. So the green bar at the bottom there is there's no treatment recorded, so it includes men who have androgen deprivation, watchful waiting or active surveillance. But you can see already that just looking across the regional areas for men with prostate cancer, all risk groups, there's quite a lot of variation. But the fantastic thing about the Prostate Cancer Outcomes Registry is that we are able to allocate men into these risk groups and start to look at variation by risk group. And you can see here that there's an enormous amount of variation even in the same risk group. So if men have low risk disease, they've got a PSA of less than 10, they've got Gleason score less than 7, and at the most T2 disease, T2A disease, then there's a huge variation in the amount of surgery or radiation treatment that goes on. You can see, for example, in Gippsland, almost 60% of men are not recorded as having any treatment, or either on watchful waiting or active surveillance. Now, of course, with the Prostate Cancer Outcomes Registry can slice and dice this data in multiple ways, so we can show this by different risk groups. And that's one of the things we feed back to the clinicians that contribute the data. We feed back the pattern of the care. The other thing is this pattern varies dramatically across age groups. So this is, for example, the difference in the rate of prostatectomies and radiation treatment for low-risk disease by age. And you can see that if you are a man who is, for example, between the age of 40 and 55 or 60, you're vastly more likely to have radical prostatectomy than radiation treatment. But the peak age for radiation treatment for these men at the low-risk group is about 70. The Prostate Cancer Outcomes Registry is following the quality indicators for men with prostate cancer over time, and they've derived 11 quality indicators which we report back to the clinicians who contribute data. And this shows an improvement in a number of the quality indicators over time. So we've been able to track indicators that indicate quality. This shows the outcomes for two of those indicators. One of them is the positive surgical margin rate for P2 disease, which is disease confined to the prostate. And so ideally in men like that, there wouldn't be a positive margin. In the earlier period, up until late 2010, we were seeing positive surgical margin rates in the range of 45 or 50%. We've seen that decrease over the last few years to come down to about 12%, so the statistically significant improvement in the rates of positive surgical margins in the state over that period of time. The figure's wrong. It was about 30%. I think it came down to 12%. The other thing that we've been following is the proportion of men with low-risk disease who have active treatment in the first 12 months. So we think that an increasing proportion of men with low-risk disease should not have immediate treatment, but should go on to active surveillance programs. And we've been following the proportion over time, and we can see here that in the earlier stages, about 50% of men with low-risk disease in 2010 up to 2011 would have immediate treatment within a year of diagnosis, and we've seen that steadily decrease in recent years. So that suggests that men are having increasing treatment with active surveillance rather than radical prostatectomy or radical radiation treatment. The great thing about the Prostate Cancer Outcomes Registry I mentioned before is that it enables us to follow patient-reported outcomes, so outcomes that matter to patients. We send patients surveys which now have the EPIC 26, so it's a validated, reliable survey instrument to allow men to report back their quality of life, health-related quality of life after treatment for prostate cancer. And we are able to provide that back to the clinician and the health service and encourage a dialogue and thought about their rates of side effects and things that they might do to improve it. And I've got a couple of slides that will show that these are just sample slides, so we can show lots of ways of illustrating this in different ways. But this is, for example, a sexual bottler. So this is the answer to a question, how big a problem is your sexual function or your lack of sexual function over the past 4 weeks? And this is the answer broken up by different treatment modalities. So you can see there's a big difference. For example, with surgery, it's 38% will say it's a big bother over the last 4 weeks. With patients who are on active surveillance or watchful waiting, as you might expect, only about 10%. Now, we can also do this by age or by region, by health service, by doctor. And so by providing this feedback, we hope that people will be able to reflect on the outcomes for their patients and think about ways they can improve it. Now, of course, this is not the only important factor, or these sort of factors aren't the only important factors for men in their outcomes. Another one might be their positive surgical margin rate, and there might be a trade-off between, for example, urinary function and positive surgical margin rate. Surgeons and patients might choose to trade those off. So we can track those too. We can do a scatter plot. And this is another example of the sort of stuff that we can do with the prostate cancer registry data. This shows in the lower left-hand corner the sort of nirvana. One would like to have a zero positive surgical margin rate, and we'd like to have no one with any big bother from their sexual function. And this shows how it varies across the state in different regions. So in Western and Central, you can see they of this group, they have the lowest positive surgical margin rates and the lowest rates of big bother with their sexual function. And just an example of the sort of work that we can do and we can feed back to clinicians. So to wrap up, we've showed that the age standardised incidence of prostate cancer has dramatically fallen since 2009. It's highly correlated with the rates of PSA blood testing. The mortality increased from 1982 to 1994, but has steadily and slowly decreased by 2.5% per year ever since then. There are lower rates of age-specific incidence in Gippsland and in WCMICS, and higher rates in NEMICS and SMICS. It's partly explained by differences in the socioeconomic class of the people who live there. Men in regional areas are much more likely to be diagnosed by transurethral resection and present with symptoms rather than be found by blood testing. And they're much more likely to have metastatic disease and high-risk disease at presentation. They are less likely to have discussion in MDM recorded if you come from regional areas, and the time from diagnosis to treatment is longer in regional areas than in metro areas. Prostate cancers are most often treated with prostatectomy, but there's large variation across the state. These are done in 42 hospitals, and they're most commonly done in the metro region and in private facilities. There's a huge variation in the different modalities of treatment across the state, and this is even for similar risk disease. If we compare, say, intermediate risk disease with intermediate risk disease, different regions, a very different pattern of care. There's a large variation in age-specific mortality across the state, and it's associated also with large variations in the patterns of presentation, the populations in the regions, the patterns of disease presentation, access to care, and the types of care available. You've all, I think, got copies of this data on your table, and we can certainly provide it. We'll also be able to provide this data back to each of the integrated cancer services. So one of the outcomes from this might be that we would encourage the people in this room to work together within their ex-region to think about the data for their region. Also, of course, the Prostate Cancer Outcomes Registry continuously every 6 months feeds data back to health services and clinicians looking after patients, and they are very happy to have a dialogue with clinicians about what the data is showing and what more might be done with the data. I can take questions, but I'd like to thank a lot of people for allowing me to stand up today and present this data. Putting aside my mother, I'd like to thank the steering group who were very helpful in sort of forming this presentation. Obviously the VIX group, particularly Morella. For data analysis, particularly grateful to Luke and then Don, who took over most of the work, helped by Ella. Fanny was very helpful back at the Prostate Cancer Outcomes Registry. And thanks particularly to Vicky Thursfield from the VCR and for Catherine from the Department of Health for allowing us to have a look at the data. Thank you very much.